This is Dan Aune, the presenter for today. I think we'll go ahead and get started, and others will join in. I'd like to thank those of you who are here for joining, and it's either good afternoon to those of you in the central and eastern part of the United States, and good morning to those in the Mountain Pacific and Alaska time zones and beyond. So I'm a technical assistant consultant with the National Indian Child Welfare Association, and I'd like to thank NICWA as well as the TA Network and SAMHSA for allowing this webinar presentation to take place. We are going to cover a broad range of history in regards to the relationship between the Center for Medicaid and Medicare and tribal health systems as a way of getting some background and leading up to understanding a guidance that was offered by the Center for Medicaid and Medicare in 2016 and the impact or the opportunity that's available for tribal nations and communities and providers. So we will have some time for questions at the end, and I would like to encourage and ask that those of you who are on to stick around and answer and complete the survey at the end so that we get more information as to what your interests are, what's important to you, how you like the platform. So we will get started. Can anybody wave at me and tell me they actually can hear me? That would be helpful. All right, sounds like we can do it. All right, great. Well, the webinar, as I said, is hosted by the National Indian Child Welfare Association in partnership with the TA Network for Children's Behavioral Health and sponsored by SAMHSA. So again, thanks, and I'll just go ahead and click through. The agenda for today is really the history of the relationship. What is the Center for Medicaid and Medicare and the 2016 guidance? How we take that information and deal specifically with State Medicaid Divisions and their role in the guidance, and then what really is the opportunity provided by the guidance. So the presentation will march through each of those, and with the objectives certainly of you understanding the history, being able to review the guidance, learn the roles of each of the partners or parties that are in this, to learn what American Indian Alaska Native health systems can do to enhance their current system, identify the decision makers that are important in this effort, and then understand clearly what the opportunities are. So we will just dive in. And please, if you have questions, there's a public chat. Go ahead and put that question in there, and myself or Vicki Wolf from NICWA or Tier will go ahead and ask. And so we have one question that we want to jump into before we go on. And so, have you previously had discussions in your health systems about the 2016 CMS guidance on 100% FMAP in the four walls? Just trying to get a sense of how much information is out there. Give a few minutes for that to percolate. And it looks like we have sort of half and half have had that experience. So I appreciate you providing that feedback. I'm going to end the poll and move along. So this will be new to some and not new to others. All right. The history, I think, becomes important to understand how long a time frame it's been that the tribes and the have been dealing with the U.S. government, and it started out that the first responsibility goes all the way back to 1803 in the Office of Indian Affairs in the War Department, and for 50 years it was there, and then transferred over to the Department of Interior, which of course renamed the Bureau of Indian Affairs for almost 100 years. And then on to the Health and Human Services with the initiation of what today we know as the Indian Health Services. So it has gone a little bit in terms of who within the federal system is responsible for the efforts around health with American Indian Alaska Natives. The IHS, you can see, has as its mission really to improve health for American Indians, Alaska Natives in lots of different ways. And so this is the manner in which they go about promoting that. I think that you'll find over time, though, there have been other both legislative opportunities and acts that have allowed for tribal communities to take charge of their own health care delivery, and increasingly there are efforts in some states to increase the nature of how a tribe may include their cultural and traditional healing and wellness practices within the healthcare delivery system. So IHS, of course, 12 area offices, 170 IHSs, or tribally managed service units, was established under Public Law 93-638. And then we also have our urban centers, which most states have them, some have more than one, and then you can see that there are some who do not have. There's an effort right now in North Dakota, a group I'm working with, to start an urban center in North Dakota because there is not one. This is a very interesting slide in a lot of respects. It talks about the population served and how that relates to the next few slides, how that relates to the non-native population. And you can see, of course, that when you look at visits, that the inpatient side's quite a bit smaller in comparison to the outpatient. On the appropriation side, the difference between fiscal year 2016 and 17 is about a 4% increase. But in 2018, that's about a 9% increase from the previous year. So it looks like about a 12% increase from 2016 through 2018. So the good news is more appropriations are headed into the Indian healthcare systems. What I find interesting about this slide in particular is the number of members actually utilizing Medicaid coverage as their payer in the systems from fiscal year 2012 to 2017. And the transitions are really interesting. From 2012 to 2013, there's a 9.5% increase use of Medicaid to access care under IHS. Then in 2014, it drops 5%. But then in 2015, 2016, 2017, it increases 9.5% each of those years. So an overall gain, if you look at the start of 2012 till the end of 2017, is that 15% more tribal members who are pursuing care through IHS are accessing Medicaid to get their coverage. And the next sort of block, you see that when you look at the utilization with the native and the non-native population, it's quite a disparity and speaks to some of the issues that go with how the Indian Health Services is funded and how prior really to Medicaid and expanded Medicaid being in place, that the limitation of services, providers, lots of reasons why the expenditure is quite a bit less than the non-native side. And I want to come back to that in later slides, because part of what we're going to talk about in this presentation is really movement from the old Indian Health Services, what I would call a bucket economy, where it's still in place. Each of the IHSs get a bucket of money. They then contract that out to other tribes who have their own healthcare systems, and that's the money that has been used to care for the population. The trouble with that is the bucket runs out, and in many communities in which I do work, it gets down to life or limb. With the advent of encouragement around tribal members who may be eligible for Medicaid or expanded Medicaid, there's now a payer that can add to the healthcare system. So instead of in the bucket economy or the granted amount, each person who walked in the door was considered a cost to the system. Now with members having a healthcare insurance product, whether it be the Medicaid, expanded Medicaid, if they're a tribal employee, tribal healthcare, and in some communities, tribes are actually buying health insurance for their members so that every member has a way to pay for health care. Each person who walks in the door to receive care actually becomes a revenue source for the healthcare system. So that movement of, if what was spent in IHS and 3,851, the goal really ought to be through healthcare innovation and healthcare encouragement for members is to increase that significantly, and we'll talk more about that as we get through this. Historically, there's the Self-Determination Act of 1975, which really begins to spell out the importance of health, the importance of self-determination, the opportunities that go with that in terms of schools and education settings, as well as the, I think, particularly involving the community in their health and in encouraging culturally relevant and bilingual curriculums for students. So we're beginning to say you can set your system up the way that works best for you. The public law, the tribal self-governance, then allows for either tribes to continue to have their same relationship with IHS. Sorry, the HIS should be IHS. But also then allows for, through Title I and Title V, for tribes to begin to take responsibility for their own healthcare system. And that may mean setting up a healthcare center. It may mean focusing specifically on substance use treatment. It could be long-term care, or it could be all of those. So that could be spread out into individual pockets in which the tribe felt they had some capacity to do that, or they could embrace that altogether. The three main purposes behind the Indian Healthcare Improvement Authorization Act, you can see, one, it modernizes the way we think about healthcare for tribes and tribal members. It reforms the system in terms of improvements over time. It adds to very specific provisions in regards to the Social Security Act. And again, if you want to know more, there's a great deal of information, but it begins to set the pace for the modernization of healthcare delivery and in terms of tribes. It starts to attack the healthcare disparities in a way that tribes can look at their own community, their own members, their own sovereignty to begin to address it. The real big jump, it may not have seemed like much, but the Patient Protection Affordable Care Act, or what is lovingly called the Obamacare, really was designed to increase access to care across the country in all communities, and more specifically for tribal communities, was to encourage participation in health insurance exchanges. So to actually have a health care product, whether it be the Medicaid, the Medicare, or commercial insurance, that each family then could pursue what was the best fit for them, and that there were also monies tied to organizations who then helped communities, members enroll or find a product that best fit them. It also began to define the difference between the Indian Health Services and then what we call the ITU responsibilities. So The I represents IHS. The T represents tribal entities, so tribal entities who have their own healthcare systems, and the U for urban. And started to identify each of those, their responsibilities, how they got paid, so that the healthcare system really expanded. You didn't have to go just to the reservation healthcare system or the IHS, that there would be other opportunities to access healthcare. Well, then we lead ourselves up to February of 2016, where CMS provided a guidance regarding what's called 100% FMAP and the 4 walls. And they call it a show letter, a state health official letter, so that's the SHO, and it's number 16002. If any of you like that, that's information I could provide for you at the end. Please, if you want that in the public chat, say that, and I'll make sure that you get that guidance letter and the subsequent FAQ letter that came out, and then another letter from that has a lot of good information to support it. But we'll walk through, and hopefully by the end of this it'll make some sense to you. Those of you who've had conversations about it probably have looked at those documents, but in essence it said that CMS wanted to provide an opportunity for tribal members to access more care, whether it be at the IHS or a tribal facility, or it be with some relationship with specialty providers. So it really reinterprets the scope of services and how and who the services are received from. So FMAP is the Federal Medicaid Assistance Percentages, and what it means is I think this is the most simple way to look at it, is for every dollar of Medicaid spent in a state, because states are the only ones who have the ability to manage Medicaid, for every dollar, it means that a certain percentage of that dollar is federal money, and another percentage of that money is state money, which comes out of taxes in the state. And you can click on the link, it'll take you, and you can look specifically at the state in which your tribe may be located, and it'll identify the level of match. And matches range from 50 to 83%, and there are now, 37 states who have passed expanded Medicaid, which means then, for those of you, just a quick, in terms of Medicaid, it's really directed at children and people with disabilities, and folks who are single and at a certain level of poverty. And the expanded Medicaid often expands that up to families. And in the state in which I live, you could be a family of 4 and make $52,000 and be eligible for expanded Medicaid, so that all members of your family could get access to health care. So back to the matching piece is every state has a different match, and those can be identified through that link. The guidance around that, just a quick snapshot for you, if you want to look at who has the lowest percent of match, there are a number of states, Alaska 50%, and then there are states who have over 70% match. So 50 means that for every dollar, 50 cents is coming from the state and 50 cents from the federal government. In states that have 70, it means 70% is coming from the federal government and 30% from the state. So again, just something to know about, and wonder if more persons who would be eligible for accessing Medicaid or Children's Health Insurance Program or expanded Medicaid, and do that and then get their services at a tribal health center or IHS, you actually are saving state dollars. So part of the work that we've got to do is with State Medicaid Divisions to help them understand that working with you and helping to enhance your ability to access that Medicaid funding actually saves state general fund, which is state tax dollars that go on. So that's the real reason why that's there. Well, let's talk specifically about the show letter. There are three critical items that it's meant. It's meant to, number one, increase access to care. And it does. It requires the Medicaid divisions in each state to work with and develop an understanding of the guidance and what systems might need to be in place that could help increase the access. And in some states it means a waiver or an amendment to the state plan. And every state, most years, they will submit what's called a state plan amendment or a waiver to increase services or change services. So this is one of the efforts here is for through the tribal consultations with the State Medicaid Division is to figure out what does this letter mean for your community or for the tribes within the state, and how can one work together. The second is there's guidance in regards to what I think is the most promising opportunity is care coordination agreements. The care coordination agreements are between, is really a referral from a tribal health system to a non-tribal provider to increase access to care for tribal members. And the care coordination agreement has some very specific features to it. And again, if anybody would like, I have a sample contract of what that looks like and what's being used, and I'm happy to share that with you. And in two states particular right now, in Nebraska and in Washington State, working on those agreements. I think in Oregon, they may already have that on the ground. But this is, since tribes are sovereign nations, they can, the guidance allows for them to do this care coordination agreement without having to have the State Medicaid Division agree to it or be in charge of it as a sovereign nation to a provider providing care to tribal members, whether they're on the reservation or in a non-reservation members. So I think it has the most potential. It does require, I think, sitting around and really discussing what the agreement means, and probably most prominent is that it's a referral from the healthcare system on the community to a non-native, that there's a sharing of the information and an accountability to the funding that's used to pay for it. Number three, the other critical item in here is around the four walls. So the guidance said that starting January 2021, no IHS or tribal health facility can provide services outside the four walls. That generally is something that you hear now that tribes are already doing. But what CMS is saying is we aren't going to do an audit on that until 2021. The problem with that is that any of us who've been and lived in or around or on a reservation know that to provide services, you have to go to where people are. So I do know that there is an attempt to review this part and to look at it at the same time. It's a guidance that's there, and that if services indeed are outside those four walls, it could create some difficulties in terms of the audit side. There is an exception there, and we will get to that. Under this increased care, of course, if the beauty of having members who may be eligible for Medicaid or expanded Medicaid or children's health insurance is that for a tribal member to getting care in a tribal facility, it's what we call 100% pass-through of federal dollars through the state to the providers in IHS tribal facility. So that's the point at which you're saving state taxpayer dollars, in that really the State Medicaid Division is just passing through that money to the tribal facility or providers at the 100% and at an encounter rate, or what's called the all-inclusive rate, which currently in the lower 48 states is about $427 per encounter, per diagnoses per day, and states have different agreements with through the tribal consultation in terms of how many encounters there could be in a day. Washington State just went from 2 encounters a day to 5. So essentially that means you could go in and see a mental health provider, you could see a chemical dependency provider, you could go to your primary care physician, your optometrist, and the pharmacy. Those are 5 separate encounters for that person that day that could happen. And so if I'm the tribal member, I could get all my care in one day and it's paid for. And if you're the healthcare system, that's a pretty good payment rate at $427 for the care provided on that day for one person. So the 100% FMAP really allows states not to have to match that, and that should be an attractor to state Medicaid divisions to work with tribes and to enhance delivery systems that are tribal delivery systems rather than tribal members taking their health insurance to non-native providers, because the 100% FMAP is a good rate and is available to providers. The care coordination agreement really allows for the healthcare provider on the reservation to contract, the healthcare system to contract with a non-native provider in another setting to provide care. And in one place I've seen it where the tribe is contracted with a dentist or a dental practice to provide all their dental services for the children. And they've done it at a per diem, so much per child per year. And then the tribe goes ahead and bills that those services and captures that revenue, but they pay the provider a per diem rate. Another way to do it that I'm working with in a couple of situations is where there's the relationship with a tribal provider who's doing mental health or substance use, and the provider is getting 70% and the tribe is getting 30%. The tribe gets the 30% for processing the claim. The information, of course, is shared and available in terms of the healthcare records that the tribe may keep and the provider, but it does provide an opportunity, again, to increase access to care, increase access to specialty care at the encounter rate. The care coordination agreements, I will go into it more. In my experience, this is the best opportunity to increase providers and access to care for members. It does just take some time. These are some of the specifics that I've offered before in terms of, the minimum requirements, and it's all spelled out in the contract as to what that means. The selling point, of course, is going to be finding the right providers, ensuring that you're not competing with something that may be in your own healthcare system. Again, though, this is a really good part of the guidance. The 4 walls, of course, we talked a bit about that. Here's the exception. If you go to bullet 2, Public Law 93-638, when it was passed, really identified tribal healthcare systems as what we call FQHCs, Federally Qualified Health Clinics. So they were identified as FQHCs, but in each state, the tribal health systems have to get a Medicaid provider number and they're identified as clinic service providers. So it gets really mucky here. I apologize for that. But the opportunity within each state then is to work with the State Medicaid Division to change the designation from clinic services to FQHC services. Mostly we identify the FQHCs with the Health Resource Services Administration, and it's quite a task to become an FQHC. Because of 93-638 and the designation in law that healthcare systems are FQHCs, really each state has just got to provide a way for the tribe to identify to state Medicaid that they want to move from clinic services status to FQHC status. This then requires a change to the state plan amendment. So again, this requires the tribes to work with state Medicaid to come up with a waiver or an amendment to allow for this to happen. And once you're an FQHC status, you can provide services outside the four walls. So somebody asked a question to CMS in a phone call about what if they had they wanted to provide services at school, mental health services at school. CMS said if you went to the school and there was an office there, but it was a school's office and you provided services, that would not be considered, you couldn't get paid for that. If you had a van that drove up to the school and kids came out to the van or the motor home and got mental health services, that would be considered inside the four walls. So I just can't imagine the stigma associated to running from the school to the motor, to the RV to get services that we would impose on our kids. But that's sort of the way the CMS has thought about it. So changing that from clinic service to FQHC really allows them to provide services in schools, to go to people's homes, to work outside the clinic environment to meet the needs of the community. It's more entangled with the State Medicaid Division and requires a consultation and the state plan amendment or waiver. But there are states who are doing it. So there is a path being paved. Again, Oregon sort of leading the way there. Again, this just reiterates some of what I've offered in a more specific detail. I just wanted to make sure that what I told you would actually be written down so you'd have that. Again, being an FQHC allows you to continue to get that 100% FMAP or the all-inclusive rate. So there are some facilities, the Umatilla Confederated Tribe in Pendleton, Yellowhawk Health Center, a long while back was designated as an FQHC. So they have been doing this for a great deal of time and providing services outside the four walls. But in talking with them, nobody can say why they did that. But somebody wiser than any of us may have saw this coming, and so they don't have to go through this process. So let's stop for a moment and think about who's important here. There's the Center for Medicaid, CMS, who sets the rules around Medicaid and Medicare. Then there's the state, there's Medicaid itself, identifies certain services that can be provided, and then in each state, the state identifies what services can be provided and be paid for. So where's the place that tribes would need to start, and it's really with the State Medicaid Division and the consultation that goes on. This is just a quick blurry map of states that have expanded Medicaid, and I just got a new chart that I was not able to get in here that identifies with this, that there are actually 37 states, including the District of Columbia, who've expanded Medicaid. That's information that took place in the last 3 months. And again, if you want to get more information on state Medicaid and tribal health systems and consultations, Here's some good linkage to find that and provide some education for yourselves. The tribes currently engaged with state plan amendments with their state Medicaid division. Oregon, Washington, Oklahoma, Minnesota, Alaska, California, New Mexico have all begun a process of working with their Medicaid or Medi-Cal, if you're talking California, to get authorization around the FQHC status, implementations of what does it mean when you expand Medicaid, what does it mean in terms of there are questions around if a tribal government has health insurance for their employees, yet they encourage their employees to also see if they're eligible for Medicaid or expanded Medicaid. Remember I talked about a family of 4 and 52,000. There are times in which the salary that you might receive with working for the tribe continues to keep you in the poverty level. There's guidance that says then the first point of billing is going to be Medicaid, and the second would be the tribal health insurance. So it gets really confusing and requires each, I think, tribe to understand that, and that speaks back to the importance of the consultation with the state Medicaid division between the tribes. And I'd encourage that any of you who either are in a position of leadership or know that be encouraged to happen. In some states, I will say here in Montana where I live, in the state of Washington, there are healthcare foundations who have embraced the tribal communities to assist with this process of having a greater say and having greater understanding. But when you begin to think about how do you make a difference, I wanted you to know that there were some states out there that were already moving on this, that the state in which you live in the Medicaid division and your tribal community could go to those states in a phone call and understand what they did to move this along. So it's good to know there are people and states doing this. I think Alaska's had a lot of success lately in transforming their system with Alaska Natives and payment around different kinds of services. That's really exciting and setting the pace for what could happen in other states. So here's really the role that I was talking about is, how do you make changes? Some of it is, get involved in the consultation. In some states, there are health alliances, tribal health alliances. Again, wanting to have a bigger say, work with the state to move from clinic services to the federal FQHC, and maximize really the implementation of healthcare strategies. Let me give you an example. I think we have a little bit of time. One community I work with, a tribal community, has 3,000 members. In their healthcare setting, those members were coming to the setting on average 3 times a year. And so and some of them had Medicaid, Medicare, even some commercial insurance. So the healthcare system was netting $3.5 million for providing services. And so we talked about prevention and maintenance and wellness, and the community did this big move to really encourage people, one, to have a way to pay for health care, so find a product that works best for them, and they had enrollers that helped to do that. Second, they did a promotion within the community in terms of billboards and education events around health, and they encouraged people to come in. And the goal was, within 5 years, to move from 3 visits a year to 20 visits a year. And remember early on I said that every person who walks in the door who has a payer really becomes a revenue source for that healthcare system. So they are in year 3, and they have moved from an average of 3 to an average of 7 times a year, and their net income for the healthcare setting was from 3.5 now up to about 8.5 million. By promoting health, wellness, health checks, prevention, so not only are they seeing folks who are have strep throat or broken arms or need stitches, they're making an impact with teaching people about health and wellness. They also are changing the dynamics of the top 5 reasons that people come in. At 3.5 million, the reasons that people came into the clinic were cancer, heart disease, obesity, depression, and anxiety. And they begin to eat away in a sense at that in terms of depression and anxiety aren't in the top 5 anymore. Cancer has moved down. Diabetes is number 1. That we're starting to change the dynamics of health by simply promoting, and they're having more revenue. And what's most interesting, too, is those revenue dollars turn into businesses. So next to the healthcare clinic, a sterilization equipment business started. A coffee shop started next to it. So it almost, healthcare can be an incubator for a community. And I appreciate you letting me go on about that. I just think that's important to understand, that if you can move towards one where you're increasing access to care, it also helps to increase the revenue available to bring in providers, to create relationships, to start new businesses, to educate your community, to develop a behavioral health workforce. And that's happening in a couple of states through the tribal colleges. The other piece here, so the opportunity, I sort of knocked on that door, you might say, earlier with what I said, but know 3 things. Know your Medicaid provider status, know what kind of health insurance products are available, and figure out how you engage that Medicaid division. Becoming partners, and in Montana, there's a foundation that brought the tribal healthcare leaders together, and they are really shaking things up in terms of having a voice, being organized, working with the state and the state Medicaid division and legislators. In Washington, that's happening as well. In the eastern part of Washington, a foundation brought together the tribes to develop a behavioral health tribal leadership alliance, where, again, a development of a voice, and they have then started this process of working with the Medicaid division to determine how they can move from that clinic service model to the FQHC provider status, and working with an urban program that's working with families who are substance use involved, and there's potential of losing their children, how to create those care coordination relationships so that there's a sustainable way to provide intensive care for Native families. So there's lots of really creative opportunities out there, and the guidance really offers that, but there are some steps to it. There are some active engagements that tribal communities and their leaders and their providers like all of you have to do. But I really think, my energy right now is going into the care coordination agreements, because that's on the ground. That can happen today. That's between a sovereign nation and a provider who would meet a special need within a community, and it is important to be able to get to that. To me, that's a thing you could do today. The FQHC status is something that's going to take work with the Medicaid division. Well, I've gone on quite a bit of time, and I wanted to leave room for discussion or questions regarding the guidance, the history, and I appreciate those of you who've stuck around. I also know there's a survey that Tiara and Samson would love for you to complete to give them more information. So I'm going to open it up for questions, and you can either do that in the public chat, or you can, I think, Pierre, can we open the phone line? So I'm going to read through the information here. So I see Stacy wants the sample contract. Happy to provide that. Really, and I will say that the slides are in the box. You can click and download those so that you have those available. And I'm happy. You can contact me at my email address or give me a call. I'm happy to discuss with you. You know, do any troubleshooting that would be helpful. This is an important guidance that came out a couple of years ago, and the sooner that I think tribal communities and behavioral health delivery systems start to act on it, the more access to care that can become available. So the lines are open, and feel free to discuss or ask questions. I think you just simply have to unmute your phone and talk. And it's simply if you got what you needed, I'm happy for that. And I understand that some people are shy and it's hard to, where do you ask the question? And I always have been told there are no dumb questions, so I'd throw that out to you. I've often been that person that will stand up and say, I have a dumb question. I think that the more that your health systems can understand the relationship with CMS and the rules that they put out, with the end goal being, can we provide more services to our members? Can we get them more access to care? One small comment, program that I'm working with now around behavioral health services, and particularly chemical dependency, they asked me to do a review of their services, and one of the things I saw was that in their chemical dependency program was set up specifically to serve the court, and all their referrals came from the court. So they were serving the court, getting court rates, not accessing the encounter rate. And if you were a family member who came to them and said, I have a family member I'm really concerned about and I'd like them to get evaluated, you couldn't get in there. So in this particular case, we redesigned that system, but we also figured out how to get access to that encounter rate, which then allowed the program to hire more chemical dependency staff. It also allowed them to hire peer support specialists, so people who have that lived experience with substance use and recovery, and put them to work. So really lots of creative things that can happen, and I want to instill in you that there's opportunity and there's hope. So if there's no more questions, we can just we can put a pin in it for today, and feel free to email or call me, and I'd be happy to be of assistance. Thank you all.